Welcome everyone to this collaboration called the Aging Commons, which brings together the various international groups and organizations. It's the Global Aging Network, which is the National Care Forum, Scottish Care, Ontario Long-Term Care Association, and the Global Observatory of Long-Term Care. And we had the experience of something called the Aging Commons at the conferences of the Global Aging Network, which is basically a way of sharing learning across academia, practitioners, and also thinking about policy. And today we're looking at climate change, which is increasingly shaping the lives of older people and the functioning of care systems. So without much further ado, we're going to go to Andrea Schmidt, who's going to give us a perspective on learning from the COVID pandemic to prepare for climate change in long-term care systems. And Andrea works for the Austrian Institute of Public Health and has made a lot of progress in this area. So we start with you, Andrea.
Thank you very much and welcome everyone. I have a couple of slides prepared and thank you also for the introduction. Is it working fine? Technically?
Yes.
Okay, perfect. So yeah, why do we talk about climate change? For those of you who haven't dealt with this topic previously, just a brief overview that is going to be followed up also in the next presentations, of course. We know that climate change and CO2 emissions are a problem for our planet. And that is not just a problem for our planet, but also for health and for population health, and particularly for people with long-term care needs, because we know from many studies by now, or there could be more, but there are a couple already, that recipients of long-term care are disproportionately affected by the impacts of climate change due to worsening care needs, health status, and rising inequalities. And in addition to these impacts, this leads also to higher demand for health and long-term care services. And that in turn increases the burden for workers in long-term care organizations, but also in social work or healthcare. And on top of it, health and long-term care services have produced CO2 emissions themselves. And so this higher demand is also contributing to worsening climate change. And that then concludes this circle of the impacts. Now, what can we do in our health and long-term care systems to tackle these problems? We can act on strengthening resilience, which is what I'm going to talk about more. And there will be another presentation by Natasha and Robin about this. And act on strengthening adaptation to climate change, so to prepare for these impacts. But we can also work on lowering emissions of health and long-term care systems. And we are also going to hear about this later on. So this was just a very brief introduction. And in my presentation, I'm going to focus on also the connection between climate change and the COVID-19 impacts. Now think back to the times of the COVID-19 pandemic that all of us experienced. And already there we saw that older adults and long-term care users were disproportionately affected from disaster, from crisis like a pandemic. And this links also to climate events that, as I said, increase care needs, costs, and workforce strain. And we saw in the pandemic also that long-term care systems are structurally vulnerable. I'm going to talk about this a little bit later. This is work that I have started and been doing together with Adelina Comas Herrera. I forgot to say this at the start because I was maybe a little bit too excited, with Liat Ayalon and David Palomera Seidel and Clara Lorenz-Stant. And we are asking the following two questions. What are the parallels between the COVID-19 pandemic and the challenges related to climate change, as well as can lessons from the pandemic inform climate adaptation strategies to ensure future responses that are preventative and just? And we're going to hear more about these suggestions later on in an another excellent presentation. Now, I invite you right now to look back together with me to the times of the pandemic and what happened in the long-term care sector there. And I have some data here from the global long-term care network that used to be the long-term care COVID network. And I'm going to share some of these data and insights with you right now. Now, the first point is we saw that the pandemic had a disproportionate impact on people with care needs. About 50, in the early stages, about 50% of all deaths related to COVID were among care home residents. And this is even more significant as only less than 1% in the countries that were part of the network are actually people in care homes. So it's a very small group if you consider the whole population, but the impact was huge. And this couldn't be explained only by age and underlying health conditions, but really system factors that mattered a lot. So think about the difficulty of implementing physical distancing because of the need for physical contact when providing care, but also the insufficient access to testing and protective equipment, as well as lack of guidance in recognizing geriatric COVID symptoms, or also asymptomatic forms of transmission. But also for many people, reduced access to regular healthcare, and also in some countries, gaps in access to vaccination for people in care homes. And that was in part also because people in care homes, but also care workers, were hardly considered when these strategies for crisis and resilience were being developed in the first place. And so that was already one of the learnings that we can take with us also when we think about climate change and how it is impacting long-term care systems and what we can learn. Now, this data this graph shows that there were, or it demonstrates the deaths that were attributed to COVID-19 in shares of care home residents across the globe. And you can see that there were large differences, in fact. And this also demonstrates the policy relevance of the measures that were implemented to deal with the pandemic at the time. And another point is that the excellent data that was collected in the long-term care COVID network at the time also showed that there was a correlation between how the pandemic was being dealt with in the community, so among where people lived and where care workers lived and where everyone was living, with the share of people who died in care homes. So there was a correlation, so we couldn't also separate these topics from each other. So that's another learning, that what happens in the community has a huge impact also on what happens, for example, in care home and in residential care. And another learning was about data gaps. So we saw, it was quite difficult, first of all, to gain the mortality data. But when we had it, it even didn't show the full impact of the pandemic. Think about the impact on well-being, on mental health. Think about what we couldn't say about how, for example, informal caregivers were affected by the COVID-19 pandemic, or also what happened to unmet needs in access to regular healthcare services. And then there were some areas such as care at home where there was no data available. Now, when you think about climate change, these gaps, of course, they remain. So we need to keep them in mind. And also some structural challenges became quite obvious, such as the low political priority for long-term care, the fact that many times there were fragmented systems and that led to no one being in charge, the lack of coordination between health and long-term care, which is a long-standing issue that we are quite familiar with, underdeveloped information systems and data gaps, as I said, but also ethical aspects and human rights aspects of people living in care homes and how they were involved in the decisions and in the measures. And then, very important, the under-recognition of care staff and under-investment in community care. There were a couple of silver linings, such as more use of technology and improvements, but only as the pandemic, of course, developed. Now, moving on to what long-term care and climate change have to do with that. Let's think first what climate change actually means and how it is impacting people who use long-term care services. It's about extreme temperatures. In some countries, it's now getting warmer. Again, we can already feel the heat, but also wildfires and droughts have been accompanying us already in the past years quite a lot, as well as floodings and storms, but also side effects such as decreasing air quality due to heat, but also more zoonosis, climate-sensitive infectious diseases that, of course, again increase the risk of pandemics, and then other aspects such as food and water insecurities, migration. If we think about recent events where older people and people who use long-term care services were affected by such events, think about Valencia in only 2 years ago, 1.5 years ago, where nearly half of all the people who died were aged 70 years and older, while they only represented about 15% of the population. And many times these were people who had mobility problems or were living on the ground floor. And then also in Japan, a study showed that after floodings, people received people who had long-term effects. So, for example, after 6 months after the flooding, they were more likely to move to a nursing home compared to people who were not affected by floodings. And when we talk about climate change, we use often a function or 3 categories, which is exposure, sensitivity, and adaptive capacity. I will be very brief on this because there will be another presentation that will show you a bit more about this. But just to say, exposure is basically a measurement of the extent of stress on a system. Sensitivity is how sensitive am I as a human being to the impacts of climate change, and adaptive capacity tells me how well can I cope with the stress that is experienced in this system. And very briefly, just some short examples, as we will hear later on more about this. Exposure, for example, think about the location and quality of housing, but also of care homes. For sensitivity, think about the fact that long-term care users are often affected by multimorbidity, frailty, or dementia, which makes it more difficult to leave in case of floodings, but also makes them more sensitive to heat impacts, for instance, and more difficult to react in crisis situations. And then that leads me already to the kind of the adaptive capacity part. Just to pick some examples, as we will hear more in the next presentation, there is a digital divide also. So early warnings sometimes do not reach those most at risk, older people, long-term care users. But also there might be care quality issues. The care workers might not be able to reach their workplace during a flooding because they might be affected themselves in their in taking care of their children or taking care of other relatives and being unable to work. And so the burden for care workers and informal caregivers is also increasing. And then, of course, as we know, ageism and ableism may also lead to deprioritization of those who are most at risk. Now, what can we learn from the pandemic to prepare for climate change as the final question? We can very briefly say that it becomes very obvious that care services need to be resilient also in crisis. And what that means is, for instance, that we need to strengthen home and community-based care to ensure the safety and well-being of the people who are particularly those who are socially isolated. We know, for example, that heat impacts those who have few social networks the most. But also the central issue of workforce training and also providing working conditions that are good for people to work in. And buildings I already mentioned, but also real-time risk assessments and prioritization mechanisms in emergencies that cover both formal and informal care systems. And then finally, also monitoring the longer-term impacts of crisis on people with care needs. So we need to go beyond just mortality numbers. So the COVID-19 pandemic also showed us that this systemic adaptive capacity is a decisive factor. And in a book chapter that I wrote with my colleague Ernest Eigner, we also came up with some other systemic ways forward that I just leave with you to finish with. First, transformational leadership could help increase disaster preparedness and while considering ecological sustainability. Second, innovative models for aging in place that, for example, take into account shared housing in walkable neighborhoods, so really with reduced emissions that address also social isolation. And finally, urban development models with green spaces and pedestrian zones that are ideally also barrier-free and suitable for people with long-term care needs. Thank you very much for your attention.
Thank you so much, Andrea. We will be taking questions later. So if you have any questions, please put them in the chat. And now we're going to move to Bangladesh. We're going to have a perspective on long-term care and climate change, thanks to Imran Chowdhury from Ayat Education, Bangladesh. Imran, the floor is yours. Yes, thank you.
Thank you. So good morning to my US colleagues and good afternoon to my UK and European colleagues and good evening to the South Asian colleagues. As Arina said, my name is Imran Chowdhury and I represent Ayat Education. We do policy research and advocacy work and some project implementation, especially we're working with the Asian Development Bank on long-term care in Bangladesh. And thank you, the organizers, for inviting me today. So I'm delighted to share a perspective from Bangladesh on the intersection of long-term care and climate change. As you know, that Bangladesh is often recognized as one of the countries most vulnerable to climate change. At the same time, we are experiencing rapid population aging. These two trends are increasingly converging, creating new challenges for older persons, family caregivers, and care systems. So today I will briefly discuss three things: our long-term care landscape, how climate change is affecting care provision, and what this means for future policy. Let me begin with the long-term care context. Bangladesh's older population is growing rapidly. By 2050, approximately 1 in 5 Bangladeshis will be aged 60 years or older. Findings from our recent ADB country diagnostic study on long-term care show that Bangladesh does not yet have a comprehensive long-term care system. Around 85 to 90% of care is provided by family members, primarily women. Formal care services remain limited, especially outside major cities. At the same time, urbanization, labor migration, smaller family sizes, and increasing female labor force participation are gradually weakening traditional family support systems. This means that even before climate change is considered, the care system is already under pressure. The key point is that Bangladesh's LTC system depends heavily on families. When climate shocks affect households, they also affect care. So Bangladesh faces multiple climate hazards. This includes flood, cyclones, sea level rise, salinity intrusion, heat waves, and droughts. While climate events affect everyone, they do not affect everyone equally. Older people are particularly vulnerable because many live with chronic illness, mobility limitations, disabilities, or dependence on caregivers. For them, climate events are not simply environmental events, they are care events. If we look at a few examples of different kinds of climate, hazards that we have in Bangladesh. So first, I'm going to talk about flooding. Imagine an older woman who lives with diabetes and hypertension, living in a flood-prone rural area and depending on her daughter for support. When severe flooding occurs, roads become increasingly inaccessible, clinics may close, and medicines become unavailable. So the result is not only disrupted healthcare, it is disrupted care. Medication routines break down, caregivers may be unable to travel, food insecurity increases, and emotional stress rise for both older people and their families. What appears to be a climate event quickly becomes a long-term care crisis. If you look at the heat stress, we know that heat stress creates a different but equally important challenge. But consider an older widow living in a low-income urban settlement during extreme heat. Without cooling, adequate housing, or easy access to water, heat can worsen cardiovascular conditions, dehydration, and frailty. At the same time, caregivers may lose work days, face difficulties, especially with different kinds of exhaustion, and struggle to provide support. Even care facilities face higher operating costs and staffing challenges. Heat therefore increases care needs while reducing care capacity. In coastal Bangladesh, salinity intrusion affects agriculture and livelihoods. When younger family members migrate in search of work, many older parents are left behind. This creates a hidden care challenge. Older people may become isolated, household income decline, and informal support networks weaken. In many cases, climate-induced migration is simultaneously creating care deficits. This is an issue that receives far less attention than floods or cyclones, but many have long-term consequences for aging societies. A critical point is that climate change also affects caregivers. Women provide the vast majority of unpaid care in Bangladesh. When climate shocks occur, women often absorb the additional burden. They manage household recovery, care for children, support older relatives, and compensate for absent family members. As resources become scarcer, their care responsibilities increase. This means that climate resilient long-term care is also a gender equity issue. What does this mean for policy? First, long-term care needs to be integrated into climate adaptation planning. Second, Bangladesh should invest in climate resilient community and home-based care systems. Third, caregivers need training, recognition, and support, particularly during emergencies. Fourth, social protection systems should better protect vulnerable older people during climate shocks. And finally, we need more research and data on how climate change affects care provision and care needs. So climate policy and care policy can no longer be developed separately. It has to be a comprehensive policy. Let me conclude with one simple message. Climate resilient long-term care is about much more than disaster response. It is about protecting dignity, ensuring continuity of care, supporting family caregivers, promoting healthy aging, and building resilient communities. As Bangladesh develops its long-term care system, climate resilience should be embedded from the beginning rather than added later. I believe this lesson is increasingly relevant not only for Bangladesh, but for aging societies around the world. Thank you very much.
Thank you so much, Imran. That was incredibly enlightening, and it was great to have a reflection from Asia. I am going to invite Robin and Natasha now to share their slides and present. So, yeah, oh, lots of claps. I'm really enjoying the animations. Uh, as Adelina said, we'll get to a discussion in time. But if people have any questions that they want us to pick up, we will do so in the discussion portion. Do you folks want to enter presenter mode and get going, Natasha and Robin? There we go.
Does
Brilliant.
that work? Can you see them
Yeah.
now?
Yes.
Yeah.
Brilliant. Thank you, folks. Take it away.
Oops, let me get. Well, thank you. I'm Natasha Bryan, and I'm presenting with my colleague Robin Stone from the Leading Age LTSS Center at UMass Boston, based in Washington, D.C. in the United States. And today we're going to discuss our findings from our review of the literature on climate change in older adults, particularly older adults who receive long-term services and supports, who are disproportionately affected by climate-related events. But at the same time, they're often overlooked in broader climate change planning and responding efforts. So first, I'm going to talk about some of the vulnerabilities of why older adults are more susceptible during climate-related events. And the health and functional status strongly impact the vulnerability of these individuals. In the United States, more than 90% of older adults have at least one chronic condition, and many rely on medication, medical equipment, caregivers, or other ongoing health services. Disasters can disrupt the critical infrastructure system and adversely affect these individuals. Then there are also the physical impairments that can limit older adults' ability to evacuate and their homes before, during, and after a disaster. And cognitive impairment creates additional challenges because individuals may have difficulty processing emergency information, making decisions, or navigating unfamiliar environments during a disaster. The literature also highlighted how social and economic factors increase the risk. Social isolation is a concern. It can prevent older adults from receiving help or emergency information, and they may be less able to flee or leave their homes from potential harm. Financial limitations also play a role. Older adults living on fixed incomes or at or near poverty may not be able to afford, or they may limit their use of air conditioning or heat during extreme weather events. They may not be able to afford transportation. They may not be able to do home repairs that can help them during a disaster, or be able to access other resources that will improve their resiliency during extreme weather. Then there's the geography. Many older adults live in high-risk areas such as coastal communities that are more prone to extreme tropical storms, or urban areas where they're affected by the heat islands. And finally, there's the ethnic and economic disparities that can increase risk. Older adults from marginalized communities are more likely to live in poverty and experience poorer health, have limited access to healthcare, and have lower quality housing. So we reviewed the literature on what are some of the impacts of climate change in older adults, particularly looking at the extreme heat or cold, poor air quality, and extreme weather events. And what we found was studies have shown that older adults face disproportionately higher risk of heat-related mortality and hospitalization during extreme weather events. One example is during a heat wave in Paris, more than 80% of the excess deaths were among those who were 75 and older. Air pollution is also associated with increased risk of negative health effects of older adults compared to younger adults, and it also is associated with a higher incidence of dementia. They are also at higher risk of mortality and spikes in emergency department visits due to extreme weather events. 3/4 of the deaths from Hurricane Katrina and from Hurricane Sandy were among older adults. Evacuation and relocation during disasters also pose significant health risks. Maintaining continuity of care can be challenging, particularly for older adults who rely on durable medical equipment, ventilators, and dialysis to manage their chronic conditions. It can be harmful sometimes to evacuate older adults in nursing homes, even when it is necessary. And the literature also demonstrates the psychological impact of disasters. Older adults experience increased rates of depression, anxiety, and post-traumatic stress following natural disasters. A meta-analysis found that older adults were more than twice as likely as younger adults develop PTSD, and 1.7 times more likely to develop adjustment disorder. So what are some of the challenges? One major challenge is that older adults are often treated as an afterthought in disaster planning and response efforts. There's also a focus on the emergency response itself, but less attention is given to prevention, education, follow-up support, and long-term recovery. The literature also suggests that many public health and emergency department systems take a one-size-fits-all approach rather than tailoring planning and response to the needs of older adults. Often, the disaster preparedness programs of most public health departments aren't designed to address the challenges and needs of older adults despite their increased risk and vulnerabilities. Another issue is that shelters are often incompatible with the complex needs of nursing home residents and community dwelling older adults with multiple functioning or cognitive impairments. And shelters often lack staff with experience caring for older adults. Communication is another challenge. Many emergency systems rely heavily on social media and digital communication, but many older adults continue to rely on more traditional and trusted information sources. The literature also highlights disparities among geography and communities, racial and ethnic and there are social inequities in attention, response, and follow-up. And older adults in rural areas may also face higher risk because of poverty, limited infrastructure, transportation barriers, and reduced access to services. Yet they are often hard to identify and reach. And finally, there's broader coordination issue. Many systems involved in emergency preparedness and response, including public health, aging services, transportation, housing, and community services, continue to operate in silos, making coordinating support more difficult. I'm now going to turn it over to Robin, who's going to discuss some of the solutions.
Thank you very much, Natasha, and thank you everyone for this opportunity. I want to highlight a couple of things in talking about this challenge. Even getting our chapter into a book on climate change and social justice was very difficult in the United States. The entire book was done and the outline was completed before anybody actually approached us at UMass Boston to write this chapter. For some reason, older adults just did not fit into their social justice framework, which I think is a challenge for all of us who work in aging services. I come out of public health, and for some reason, public health does not seem to view older adults as a population of priority. So for us, this was a labor of love just in terms of even getting this issue on the agenda of this particular book, which was published, and the citation is at the end of our presentation. But it shows, I think, the challenges that we have in actually keeping this on the radar screen. The question around preparedness and education, I personally think that this is one of the most underdeveloped areas. We seemed in the United States to have done a lot more around emergency response, as Natasha was saying, but not very much about early preparation and education, including the local agencies and the professionals who are assisting older adults in developing plans for an emergency. That includes everybody from family, but professionals who work with older adults, physicians who should be on the front line of making sure that older adults are prepared and that they understand their own risks. Because not only are older adults vulnerable because they are a higher risk for chronic conditions, but they present differently in climate change events. Their effects around heat or cold are very different from younger people. And so physicians and other folks who take care of older adults need to understand this, and they need to make the families and the individuals themselves aware so that they have plans earlier than when the emergency hits. We also need community outreach, particularly working with home care aides, community leaders, and peer educators who community workers who are going into the community who can actually reach out with education before the problem hits, accessible communication with large print, good audio, and in multiple languages. In the United States, we are incredibly diverse, and we need this material in languages to actually meet the needs of a very diverse population. And then finally, we have to map and register at-risk older adults for targeted support. We believe very strongly that the public health system in the United States and other parts of the world need to think about these issues as surveillance challenges so that we have maps of where folks are at risk and we can address this beforehand and not wait until an emergency hits. Natasha, can you move to the next slide, please? The agencies, community leaders, and providers include these older adults themselves, their family caregivers, and frontline staff in local, regional, and emergency planning. They need to be involved. They need to co-create any plans that are made at a community level. We also have to empower community groups to register at-risk seniors, perform wellness checks so that they understand these high-risk folks and where they might be moving into danger zones, and distribute guidance kits for folks to actually be able to prepare for the various activities. And just all the wildfires that we have been having over the past few years in the United States is an example where there was never enough preparation for older adults to actually have to deal with the consequences of the wildfires, including getting out of their communities on time. There needs to be partnerships specifically across public health, social services, transportation, and aging services to share data and coordinate this outreach. And finally, co-developing age-specific protocols, guidelines, and checklists, integrating into the broader disaster plans and delivered by trained people. We move to the next slide, please. The frontline professionals who are serving older adults need to be able to think about using client assessments to actually map the vulnerabilities and to anticipate needs. In the United States, we have a whole system of aging, area agencies on aging in many of our counties and many of our states across the country. Those entities and other entities that work with them, including public health departments, need to do this all the time. It's not just a one-off. It has to be systematic and it has to be consistent. Secondly, we need to have training, specific training around how do you support individuals based on their needs? How do you educate them beforehand, support them during an emergency response? And as important, what is the follow-up? I was the Assistant Secretary for Aging in the 1990s when we had several hurricanes in the United States. And I can tell you 6 months later, we were still finding people in rural areas who did not have any electricity and any access to any kinds of services. This is 6 months after a hurricane. And that's in a very developed country. So we have to really think about not just the emergency response, but the long-term follow-up of these populations, reconnecting individuals to the shelters, their care teams. Financial and legal aid are going to be needed at that time, and monitoring for delayed health impacts. This is particularly true in Puerto Rico, where we had a horrific hurricane and flooding, and we lost many, many older adults. The electricity was out. A lot of people were on medical devices. No generators were there, and it was just a nightmare. So this preparation and follow-up is essential. If we can move to the next slide, Natasha. Evacuation and relocation. You got to plan for the transport and designate age-friendly or special needs shelter areas. We cannot have shelters that don't know how to do medication management for older adults. This is not a general population issue. It is for older adults, which is very different from the average adult population or children. We also have to assure that there are adequate and appropriate supports and resources, relocate to areas where informal support networks can provide the care, and advocate for shelters staffed by professionals experienced in older adult care. I can't underscore this enough. This is a challenge that happened in Katrina in New Orleans, and it was horrific. The aftermath was really terrible. If we move to the next slide. Recommendations include equal attention to all elements of climate change related activities focused on older adults. That means prevention, early education, emergency response, immediate follow-up, and long-term follow-up. All of those activities have to occur. We have to have age-friendly public health, hospitals, and health systems and shelters in order to address these issues appropriately. We have to have appropriate and very targeted communication strategies that are culturally competent. We have to have federal, state, and local agency coordination and better community level education planning and coordination. And finally, I would say attention to population and geographic disparities, which is probably the most critical. It is not the same dealing with an older adult population that is living at the coast versus those who are living in very rural frontier areas versus those who are living in urban heat or urban cold areas. So we really have to recognize the idiosyncrasies of these various geographies and how we address each of them in different ways. And I think that's it. If we move to the next, this is the chapter. And we also have an issue brief that we did, a research report from Leading Age. So please avail yourselves of both of them. And thank you very much.
Thank you so much, both. I'm sure there will be lots of, there we go, lots of claps coming in. Brilliant. Okay, well, we've got one more presentation to go, and then we'll go on to a discussion. I can see some questions have already come through, and we've spent a lot of time talking about the impacts of climate change, and I think the last presentation is going to be quite interesting because it's going to be talking about care home decarbonisation, and I will pass on to Dan in that case, and take it away, Dan.
Thanks, Finn. So I'm going to talk about three interlinked pieces of work today. My name's Dan Hind. I'm from the University of Leeds, but I really want to give credit to people who are much more expert in many of the things I'm going to talk to today, including my colleagues from the School of Nursing and Midwifery at Queen's University Belfast, Gary Mitchell, Steph Craig, Tara Anderson, and also my colleagues elsewhere in the University of Leeds in the School of Earth, Environment and Sustainability, John Barrett, Jonathan Norman, as well as a raft of other people who I'll sort of mention. So why do care homes matter for sustainability? Well, in England, we have about 410,000 residents across 11,000 facilities in very sort of energy intensive 24/7 facilities. And we know that healthcare accounts for about 4 to 5% of global emissions, but care homes are overlooked in research and policy compared to especially acute hospitals. We know from one Australian study that aged care contributes comparable emissions to sort of health services more generally, 48% of total emissions from a health provider across all three scopes. So there's a big evidence gap about how contributory sort of long-term care facilities are in terms of sort of carbon emissions. And in England and the UK more generally, we don't have a sector-wide carbon baseline. Providers, unless they're sort of very large companies in the UK, don't know what their footprint is. There are sort of mandates that kick in the UK for companies with 250 employees or more. And a lot of the hospital-based interventions that have been developed to decarbonise our National Health Service, our NHS, probably aren't going to transfer directly. So there's a sort of research agenda sort of waiting to happen here, which can deal with the distinctive challenges of care homes in the United Kingdom, which, unlike hospital wings, can't close for retrofits. They have particularly vulnerable residents. They have very tight operating margins, and there's a plethora of different ownership structures with different potentials in the UK. So the first piece of work we did was to map the evidence on care home decarbonisation in a scoping review, which was published in December. And we looked at sort of care homes, what some people would call long-term care facilities, their residents and their staff. And we were interested in sort of any peer-reviewed paper which was about decarbonisation in any geographic location, studies monitoring energy consumption, implementing or modelling decarbonisation strategies, or exploring the experiences of such strategies. And we extracted data from the papers that we retrieved, sort of coding them using the greenhouse gas protocol in terms of scopes 1, 2, and 3, which we'll talk about in a minute. I should say up front, one of the sort of the weaknesses of this review, it was done very rapidly. We didn't have time to incorporate a vast quantity of grey literature which exists out there. So this is only what gets into the peer-reviewed record, and that's a key limitation of our work. So we ended up including 22 studies from 14 countries, and these were predominantly quantitative sort of modelling studies, not sort of empirical observed data studies, with 2 qualitative research studies included as well. And care home ownership was rarely reported, and that's an issue for the UK, where we have a very sort of mosaic structure of long-term care facilities, different ownership types with different potentials. So scope 1 is the direct facility emissions, and this is the most neglected scope. There are only 3 studies, one from Japan. Interestingly, the 2 UK qualitative research studies had findings in this scope, and were sort of interesting in sort of identifying some of the barriers associated with older people who tend to sort of value electric fires not just for their heat but for their coziness and their glow. So actually trying to persuade care home residents to not use an electric fire which has kind of carbon emissions that might be undesirable is quite problematic. We also found a certain amount of risk aversion amongst managers relating to unfamiliar technologies. On the one hand, people need to keep occupancy rates up to make the business model sound, so you can't depopulate a care home to do retrofitting very easily. And there's also fear about unfamiliar technologies in the sense of if we can't operate this, if something goes wrong, there'll be reputational damage for us trying to sort of do the right thing and it sort of backfiring. There's far more evidence in scope 2, which concerns purchased electricity, and the findings across the 14 studies included the savings that you can derive from retrofits and passive design. These are modelled sort of savings. They're not observed savings as yet. That smart monitoring could reduce consumption, heat pump installation could cut electricity use, as could thermal comfort models. But these findings are sort of regionally dependent and mostly models, as I say, not real world findings. And then there was not a lot of research on scope 3, which is about the supply chain. All 5 of the studies focused on food and menus. A lot of work on animal sourced food, so the transition from meat to plant-based diets. This can cut food emissions and with minimal cost increases and nutritional improvements. But there's no studies that we identified on procurement, on waste, on pharmaceuticals or other supply chain domains. And we've heard recently that there's a lot of interest in in aspects like sanitary towels and sort of incontinence pants, how you sort of deal with that sort of ecological cost. But while still getting it right for the care home resident. And there is also a lot of interest in sort of cutting sort of food portions to avoid leftover food, and that's a sort of good way of cutting waste that has to be handled sensitively. So we concluded our paper with a sort of graphical model which summarized what was in the literature, and effectively there are these three scopes, these three different categories of interventions through which you can reduce direct facility emissions, purchased electricity, and the procurement chain. And in theory, those should lead not only to reduced emissions, but depending on electricity production in your region, lower costs, and something we haven't talked about much yet, but I will in a minute, health co-benefits. But there are sort of moderating factors, barriers in many cases that we've talked about as well. In order to really kind of grasp the nettle here, people need to understand the emissions measurement. And a lot of particularly small and medium-sized enterprises in the UK don't at the moment. They need to navigate operational constraints, competing priorities in terms of care home management, and a general sense of risk aversion. And ultimately, you also need to navigate resident behaviours as well. Care home residents, are the clients. They're there to be looked after, and they have their own preferences and priorities, which need to be navigated. So there's no comprehensive baseline footprinting of carbon emissions across the three scopes yet. There's no sort of decent cost-benefit analyses that are tailored to long-term care facilities. There's limited implementation science published around this problem. Health co-benefits are rarely quantified, and qualitative and behavioural dimensions are probably underexplored. What we can say, because an enormous amount of money has been, and policy imperatives have been sort of put into decarbonising the NHS by 2032. The social care sector in the UK is definitely lagging behind, and that's not surprising because it's mainly composed of small and medium-sized enterprises or non-profits in a hugely fragmented sector, and which has got a lot, has got a perfect storm of difficult operating conditions to deal with. The next piece of work I want to talk about is a stakeholder engagement workshop that my colleagues in Queen's University Belfast, Gary, Nuala, Steph, and Tara did with around 80 people, and they were really sort of looking at how decarbonisation in care homes should or shouldn't be treated as a purely technical or environmental issue. And the conclusion they're going to come to here, based on what people told them in the workshop, is that you've got to treat this not as a technical or an ecological issue, but as a gerontological care quality priority. And if that sounds like a stretch, bear with me. So first of all, there's a lot of literature in housing and public health that links indoor environments to health co-benefits, and emerging co-benefits evidence sort of came from our scoping review, and it's coming from other sources at the moment as well. So there is a sort of an emergent literature on climate and aging, which we can apply to sort of the vulnerability of our care home residents. But if the sector only talks about carbon metrics, it sort of misses out on what will actually drive change. The core concerns that are really sort of embodied in the carer workforce and management. So as I say, there were sort of 80 people who were care home managers, nurses, care assistants, the relatives of care home residents, and other sector stakeholders. And what we found is that is that sustainability is not experienced as an abstract net zero target. It's encountered through things like, heating control, lighting, waste, food procurement, workforce habits, financial constraints, and uncertainties about the effects on resident comfort and choice. So we developed this conceptual model. Excuse me, I'm just going to turn off my captions if I can, because I can't see the bottom of my own slides. No, I can't, don't worry about it. So there were lots of sort of themes around sort of heating, ventilation, insulation, and lighting. Lots of things about food procurement and waste, people wanting to know more, how to do it better, very enthusiastic about that. Lots of things about workforce capability and culture. There's curiosity, but at the moment there's a sort of lack of knowledge, skills and confidence, and the habits aren't ingrained that are going to bring about sort of net zero practices yet. Lots of talk about how this whole issue requires a leadership change, within individual care homes, within care home companies, what we call multiples, companies that own more than one care home. And how to make this kind of people accountable, and that sort of also requires meaningful metrics, and these domains are all interdependent. So the last piece of work that I want to talk about is looking to the future. Now we have a grant application under consideration at the moment. It's a two-stage grant application. We have an application in at the first stage. So this is funded. We've got to get through another stage before that will happen, and this work won't start until spring next year, 2027. It's a piece of it's a commissioned call from the National Institute for Health Research in the UK, and we've called our project Green Care: Generating Emission Evidence for Net Zero Care Sector Action Roadmaps and Evaluation. And what we're aiming to do is establish comprehensive carbon measurement for UK care homes, identify the barriers and implementation strategies for its use, look at the economic drivers, not just in terms of abstract cost effectiveness models, but return on investment models for care home managers, and then devise a series of knowledge mobilization strategies. And at the heart of this project is a carbon accounting platform that's being developed by my colleagues elsewhere in the University of Leeds, John Barrett and Jonathan Norman, in collaboration with the UK government's Department of Energy, Sustainability and Net Zero, DESNI, as you're going to see it said here. So they already have funding to produce this platform, and they're interested in making it available later on this year and in the beginning of next year for small and medium-sized enterprises. And it would help small and medium-sized enterprises convert expenditure and activity data into scope 1 to 3 emissions estimates. And this is not as sophisticated as what larger enterprises in the UK have to do. But those larger enterprises will generally be spending about £8,000 on consultants with models that frankly aren't very transparent. And there's a bit of a sort of wild west of sort of non-transparent models out in the UK at the moment. By contrast, the cost of using this University of Leeds Department of Energy Sustainability and Net Zero model will be £50 per year, and so much cheaper than the sort of commercial alternatives that are really not viable for small and medium-sized enterprises, let alone non-profits. So this
Dan,
is
just quickly, sorry, just because we need to get on to the discussion, would it be all right to just go to the summary, if that's all right, just because we need to move on?
Absolutely, yes.
Fabulous.
There's a logic model there. So basically, from the summary, we have a fragmented evidence base dominated by scope 2 emissions at the moment. We probably need to work with the sector to reframe decarbonisation as a care quality issue. It's not just about carbon, it's not just about the environment. And we hope that our study will directly address these gaps. Just very briefly, while I've got the platform, I want to mention another study that is already in progress at the moment. This is funded work that we're doing right now. called Social Care Heat Action Implementation to Protect Everyone in Long-Term Care and Domiciliary Services. Currently doing a consultation to deal with those issues of the fragmented system, how we get care homes and domiciliary care providers in the UK into an emergency preparedness, resilient and response cycle to keep vulnerable older adults safe in heat waves. And if anybody else on the webinar is doing that kind of work, I would love to hear from you. International sort of knowledge exchange has been really important for this project. We've been speaking with people in Brisbane and also in Canada about how they've been dealing with this problem. So the sort of cross jurisdiction sort of fertilization of ideas is kind of like really important. Thank you very much, and apologies for overrunning, Finn.
Thanks, Dan. Thank you so much. I think we'll move on to the discussion now, but I mean, just to start by saying thank you to everyone who has presented so far, and particularly Dan, that was great. As you can see, the applauses are flying through. We'll head into. I'm not sure if someone can set us up to be spotlit, and we can get all of our speakers together. Adelina, do you want to segue into the next section?
Yes, so we're going to have a Q&A with a chance for discussion. I recognize some names in the call of people who I know are working in these topics in other countries, including some Irish colleagues. Hi, Thomas and Dimitra. I wanted to just raise one thing. So just to kickstart the conversation, and I was thinking about these emergency situations, thinking about Imran's presentation, Andreas, all of them actually, also Natasha and Robin's and Dan's. There is something about the emergency preparedness and the awareness that the existing or the main responders that we have of older people. And I'm just going to give, this is an anecdote, but when the Ukraine invasion started, one of the things that happened is that usually the emergency services that go to these conflict zones are used to working in countries where there's a much younger population. So their emergency kits contained nappies for young children. They didn't have any continence products. And of course, the Ukraine being a European country had already a much more aged population, which meant that they didn't have suitable kits for these older people who are being displaced and impacted. So I just wanted to raise that, and I just sort of invite the colleagues, and including Imran also, on what you think about the role and how we can reach these international organizations or the main bodies, or sometimes the army, or that are responding to emergencies, and their awareness of older people.
Who wants to go first?
I can
in any of you. Yeah.
I can maybe speak a little bit about one question that was also asked in the chat regarding how to organize basically preparedness also at an institutional level, and maybe it helps get the discussion going on your question as well. So we've been comparing also countries, and what we are also seeing at a national level is that in particular mobile long-term care services, but probably also other organizations, are not considered when it comes to emergency preparedness, or they're not involved. I mean, I think the classic emergency services, they would probably be able to connect with each other if you're thinking about ambulances and fire brigades, for instance, or like the classic emergency services. But many times, in terms of the preparedness strategies and the councils that exist, mobile long-term care workers particularly are not, or social care is not sitting at the table with people. And that refers not only to floodings, but also, for example, to preparing for heat waves. And I think this aspect on how we can actually get people to sit at the table with those that are creating these emergency and preparedness strategies is where we're still seeing a gap, despite what we experienced in the pandemic and other disasters, as Robin also mentioned.
Yeah, I mean, in the United States, nursing homes are considered first responders. So they are our Centers for Medicare and Medicaid Services, which is the overarching agency for the entire country, we have 51 states, and we have about 17,000 nursing homes in the United States. They are all required to have emergency plans. They have to demonstrate those emergency plans. They get tested and audited and surveyed on those emergency plans. And they are actually built in. I mean, I'd say we do a fairly good job of nursing homes as first responders. But the problem is most of our long-term care population is not in the nursing home. We only have about 1 million people in the nursing home. We have millions of people in the home and other residential environments. So our challenge is that we have so many settings, and that there is nothing that overarches the populations in these communities, and which is why personally I think, and I like the idea of also thinking about the military. I mean, whoever is in this first response activity, but public health, these are public health issues, all of this. So if we don't have a robust public health system that is everything from the local to the federal level of really addressing the ongoing normalcy of climate change, it's not an aberrant activity. I love the decarbonization and the focus on also trying to deal with the challenges of it, but we also are in the midst of it. So I think that is really critical, and maybe an international call around public health to actually think about this as a serious challenge would light a fire under certain entities, because the investment just isn't there.
That's a really good point, Robin. And I think one thing that the Global Aging Network has been calling for is for a charter on sort of older people's rights. And I wonder if by igniting those calls and saying that actually climate change and adverse weather events are a risk to older
people,
a
risk. I mean,
at a UN level would create some kind of impetus.
The best country that I've seen is Japan, partly because they're so darn old. When they had of course this wasn't, it was probably climate related, but the power
tsunami.
And the tsunami that followed, they had so many protocols in place to actually deal with older adults, specifically dealing with older adults, because they have so many older adults to begin with. So, and even there, they didn't do a fantastic job, but they probably did a better job than a lot of other countries. So we need to acknowledge that this is as big of a risk as a lot of other things.
One thing that struck me is how, this is a globalized issue. Everyone has experienced climate change in varying forms, but they're experiencing it in different ways. Imran, you talked about salt. That's
salt.
Obviously not going to be for a community in the Midwest might not be of concern, but it still connects to climate change. I wonder, hearing everyone's reflections from around the world, do you see a common thread? That's for you, Imran. Just apologies.
Thank you, Finn. So before coming to this question, just to add with other colleagues what they have said about, when examples of climate resilient LTC system. So in Bangladesh, you know that we don't have that system yet, but we can build on some good examples. For example, we have community-based volunteers who are trained in disaster preparedness. But if you can develop a model for community based long-term care system, then they can be well trained to identify vulnerable people, identify the kind of interventions that we need to do before any disaster happens and during the disaster and after the disaster. So those kind of things we can build based on the existing system. And another thing is that there's a growing use of home-based care services and digital health platforms in Bangladesh, which can help maintain continuity of care when floods or other climate events disrupts access to facilities. Flood response and resilience building. I'm sorry if you can repeat your question about the salinity.
It was just that there's clearly, despite, we're all talking about climate change, there are clearly, it affects different places in different ways because that's how geography works and that's how it all, but there seems to be a common thread. And if I can pick up on what you said, Imran, which really struck me actually, was that a disruption to a household is a disruption to care. I think that's a really interesting concept, particularly in economies and countries where the majority of care is personal care at home from a loved one. So I wonder if there's these realms of that we have to consider, the household, the community, the country, and international, and start to think about our responses at these different levels. That was what I was struck most by with yours, Imran.
Yeah.
Dan, we've got a question in the chat. Just want to pick that up with you. It was, I wonder what extent decarbonisation of care homes can also be linked to better preparedness for heat waves. For example, solar shading systems to reduce overheating or solar PV to run cooling systems. I understand something building regs for cooling buildings only applies to new build and not to existing buildings, but measurable also in retrofit. Thanks, Jim. Do you want to pick that up, Dan? There's a few things in there.
I've just finished my response with a typo. Yeah, so my presentation, thanks, Jim, it's a great question. And my presentation slightly skated over the health co-benefits, which I think you're hinting at there. Yes, what to say? I think we talked about the challenges for many small and medium-sized enterprises, care homes, long-term care facilities, in terms of being able to retrofit. And it's a real problem because the housing stock in the UK is famously poor. And this is a concern for local government as well, who are really concerned about sort of, the housing stock in which some of their domiciliary care clients are living. Often what we're talking about is, sometimes, the appalling, post-war buildings, but often it's people sweltering in the attics of Victorian sort of 19th century and early 20th century sort of buildings with sort of no insulation. And in the case of care homes, it's their carers working 12-hour shifts who are also sweltering, to the point where they're unable to do their job properly. And our patient and public engagement exercises have expressed equal measures of sort of concern for the care workers as for their relatives, because they see what they're going through and the pressures they're under. So there are definitely sort of health code benefits which include thermal comfort both in the winter and in the summer if you can afford the time and the money to sort of retrofit, including insulation. There's also infection prevention and control sort of benefits from better sort of ventilation systems. I think there's a really interesting sort of parallel agenda. I was fortunate enough to be involved in a round table run by a charity called Foundations UK, which is it's a foundation sort of a charity devoted to the people who often do buildings modifications for local government, often for people with disabilities, but they're starting to get interested in whether they should be responsible for fitting sort of reflective materials to the outsides of buildings or certainly windows, because if you're trying to cool down a building, the best thing to do is to stop the heat entering in the first place. And there are some sort of low cost ways that you can do that with some buildings. So there's a sort of like a a whole sort of buildings modification agenda, in place. But just in terms of, the immediate health co-benefits of not being under a roof that is overheating. There's some great work going on from the University of Heidelberg. A lot of researchers there have been doing sort of work on, painting roofs or lining roofs in Burkina Faso with sort of heat reflectant materials and really good sort of physiological and kind of mental health kind of data in these kind of randomized control trials. They're running it sort of running out in sort of low middle income countries. Not seeing anything like that technology transferring into sort of the UK yet, which is really interesting. I hope that answers the question. That's a bit of a ramble, but
thank
there in the
you,
chat.
Dan. You may have seen in the chat, but Adelina's had to hop off, so she said she's left you in my capable hands, but we'll see how that goes for the rest of the session. So I suppose thinking about the impact of this. We've got Thomas with a question. I'll bring you in.
Okay, thank you, Finn, in your excellent hands. Yeah, look, the presumption of evacuation from older persons' houses and long-term care is a bit of a problem, right? I mean, and I think there is often in planning and design this assumption and presumption of safe and easy evacuation that's applied in a very kind of simplistic kind of model. So I'd just be interested in getting the panel's thoughts on that. That's kind of, rethinking about a lot of these settings in terms of moving away from this kind of simplistic evacuation model that's, assuming that's the best or easy response in all cases.
Fab. Okay. Can I come to you first, Andrea?
I'm not 100% sure if I understood the question because the sound was a little bit.
That's okay. So the question is
Right.
that there's a bit of a presumption that evacuations are safe and easy, regardless for older people. That necessarily isn't always the case. There are complexities and that it's the best thing to do for them. I guess what I took from your question, Thomas, is how do we shift that perception, and what are the other exploration? What are the other alternatives we can explore? I suppose.
Yeah, it's a quite tricky question, and in fact, as I also showed briefly in the presentation, we do see that that the evacuation is a problem if you think about people with dementia, for instance, as was mentioned also by others. For care homes, I find it quite difficult to answer this question. I can maybe start by answering it for people living in the community, who are, as was also mentioned in one question in the chat, are often not identified during emergencies. So we have a real issue there also in identifying people who are socially isolated, who have no social networks, maybe also no formal care services or very limited ones in terms of prioritizing them. So I would say that would be for me the number one action in terms of improving evacuation strategies, because and that involves, of course, also the broader network. So I hear from people who are experts on emergency and preparedness that it's mainly so basically when if you think, particularly if you think about floodings, but it applies also partially to heat waves. It's the neighbors first that are kind of the first response strategies, and there, of course, from a public health perspective and also a public economics perspective, we need to be careful not to leave these networks to answer, to be the key people responsible for responding. So we need structural answers in our formal long-term care services, and not rely on neighbors or other private persons to save people who might need help. So yeah, I would be starting from there, but maybe someone else can respond also or add on to the care homes question.
Brilliant, Imran. Please do pick up where Andrea left off.
Thank you. Yeah, I just wanted to add with Andrea that from Bangladesh perspective, I mean, share some experiences. So we don't have, like when community people's database, like when we do different kinds of projects from different NGOs and different, government initiatives. But if we had a database of our community people, especially the vulnerable people, the people with disabilities, people with other conditions, then we can also mobilize our youth volunteers to work during the preparedness period so that they can, evacuate them on a priority basis. At the same time, we have some community clubs, we have some community centers where we can provide, we don't have devices, for example, wheelchairs or beds to rescue the, people with different kinds of conditions. So if you can provide those kind of devices in different communities based on the data, then maybe that can help us to plan some, interventions before the disaster strikes. So maybe that way we can save some lives. Unfortunately, in Bangladesh, infrastructure is a big issue. In rural areas, accessibility to different communities is still a big issue. So maybe when we plan any kind of infrastructural development from government, from policy perspectives, maybe we need to think about one, if it is climate friendly, second, if it is older persons friendly. Thank you.
Thank you so much, Imran. Robin, Natasha, do you want to come in on that?
Oh, I was just going to say, also picking up on Andrea's comment about people in the home and community, those are the most vulnerable people. And a lot of times those who are receiving supports may have caregivers, and to utilize those folks more, they will understand their needs, they know the medication, so they could be part of preparing them should there be an evacuation of what their needs might be. And then when we evacuate people to shelters, as Robin mentioned during the presentation, we need to make sure those shelters can accommodate the complex needs of those older adults. If people are on medications, people may have mobility or cognitive issues. So how we have because we find special needs shelters, at least in the United States, but often they don't know the older adult population. So we need people who are really trained and can support them in those shelters.
Yeah.
I can just add a couple of things about the nursing home in particular. Obviously, the literature does suggest that there is dislocation effects, and there is higher mortality and challenges around depression as well with moving people. Leading Age, which is the association that Natasha and I are associated with, is a very large association of about 5,600 providers. And we have set up systems where there is actually buddies that get put together so that if there is an evacuation, we have actually been able to evacuate full populations to other places in other geographies. And everything is set up to actually do both the relocation, but also supporting the staffs who are just as hit by these challenges as the residents themselves. So they're thinking about, and as you would talk about at the individual level, thinking about how organizations might mobilize themselves to make the evacuations easier. It is very, very problematic. There's no doubt about it. But we've had a huge Mobile, Alabama. We moved hundreds of people out of there to the Armed Forces Home here in DC, did it very well, supported all the staff. And this was done by what we are in essence an NGO is what the Leading Age is. So I think there is capacity there to do that. But again, it can't be a one-off. This has to be really organized and well thought out. Climate change is with us for the foreseeable future. So
yeah, we've just had in the UK, we've just had the hottest May on record, which for those of you in hotter places was, I think, about 32 degrees, which is not very hot.
And older adults will, their response to that is horrific. So
I think we're coming to the end now. So if I might suggest, my for my key takeaway from today, and I'll invite all of you to perhaps share your reflection in a sentence. But my key reflection from today is that there are things that need to happen at individual, household, community, national, and international levels, but they have to interact and they have to be systematized. Otherwise, if you leave it to ad hoc, piecemeal arrangements, difficult things happen. And Andrea talked about that in the context of the COVID-19 pandemic. But I think there are some ample learnings for us to take going forwards. If I can invite each of you to just share a quick reflection on today, and we'll finish up. Robin, you first, please.
I just thought this was a great session, and the theme across all the countries, regardless of what stage we are in, I think is really pretty critical. I was struck by Bangladesh, and actually I think Bangladesh has in some ways more potential than some of our more structural, our facility-based or entities, because you may have a community base of volunteers that are more used to doing this kind of thing. And as we think about sort of surveillance of where people are, the other was I hadn't thought about the decarbonization and the role of the long-term care sector itself as both a contributor to the problem and also being part of the solution. So I love how that was all put together.
That's fantastic. And that's a neat segue into Dan.
Thanks, Finn. You've just sparked something. I'll put it in the chat, but I'll say it out loud. It's often the spring heat waves. The heat wave season in the UK is supposed to be from the 1st of June to the 30th of September. But as you've just said, we often get one in spring, in May. And in 2022, that was one of the most sort of dangerous ones. And it was not necessarily people in the hottest places that died in larger numbers. It was people in the most economically deprived and the most multi-morbid places. So that's a good sort of note to leave people on with that sort of inequalities angle if you're thinking about climate adaptation for vulnerable older adults.
Absolutely. Imran.
Sure, thank you. So first of all, I learned a lot, especially, like how you can, we talk about older people, we talk about long-term care, but at the same time, how you can think about, the building greener, facilities. For example, there's a good thing that Dan shared is the green care. So I would also thought, think about that when we designed any, senior citizen home or, community-based care system in Bangladesh. So we'll also think about that model. But at the same time, I just wanted to address that, mention that we know that we need, climate resilient long-term care system, but at the same time, we need to ensure that we are leveraging technology and AI so that we can build some robust models at the same time. Thank you.
Thank you, Imran. I'll bring in Andrea, please.
Thanks. Following up from my presentation, maybe to say that some of the solutions are already at the table. So what we need to do is really get also the political action on the ground. So we as researchers can, of course, try to highlight from past disasters, be it the pandemic or other disasters, as was mentioned in the US. But I think many of the solutions and the fragmentation problems are already on the table. And at the same time, I think we shouldn't think about climate resilience in the long-term care sector as separate solutions, but really always try to combine it with all the challenges that we are already facing. And that concerns particularly workforce solutions and also informal caregivers. Thank you.
Thank you so much, Andrea. And finally, Natasha.
I would say thank you. I learned a lot from all the presentations, and I would say is that you see climate changes here. There's a lot of vulnerabilities among an older adult population, and the more different agencies that have expertise in the different areas can work together and really make sure those vulnerable people are ready for and can be taken care of during and after evacuation or climate-related event.
Brilliant. Thank you so much, Natasha. And I'll draw the session to a close. So I just want to thank everyone again for their fantastic presentations and thoughtful contributions. Likewise, Naz for helping support the session, and to I know she's not here, but Adelina for her brilliant chairing. I think I'll end it with a consideration, which is perhaps slightly depressing, but I think it's an important one, which is every death that we've heard about today is not an abstract thing. It's a direct human cost, and this requires urgent action because, human lives are worth protecting. So I think this is a really valuable session today, and hopefully we can go forward with some renewed vigor and some fire in our bellies and get going again. So just to thank everyone for your attendance, and to wish you a lovely morning, afternoon, and evening, depending on where you are. Thanks, folks.
Bye, everyone.